Autumn, I'm giving it up.
Thank you. All right. Well, good afternoon, everyone. So first and foremost, I want to thank everybody that is attending today's presentation. I love mental health. I have such a huge passion for it, but I really have a passion when it comes to eating disorders. It's something that I've worked with in the past, and I'm so glad that West Virginia is, starting to really take notice and talk about eating disorders and self-harm that is going on with our youth, because we have seen such a significant increase in these issues, especially since COVID has started. So I love that everybody is here wanting to learn. So I did a presentation on eating disorders a couple months ago. I'm not sure exactly when. That was more for like parents, community members, kinship caregivers, things like that. So today there's going to be some differences if you attended my first one. So I will still go over some of those eating disorders, some of those symptoms and what to be aware of and what to look out for. But I'm also on helping somebody. We're going to be looking at it more of a clinical way. So I will go over the diagnostic criteria of these eating disorders, as well as a couple of different therapies that have been shown to be effective. So let me go and share my screen. I'm going to share sound. All right. So Becky, Hillary, can you guys see my screen, hear me? Are we all good?
Yep.
Perfect. Yes. All right. So just a little bit about me. I always just like to introduce myself a little bit more. So again, my name is Autumn Wagoner, and I'm the Youth Resource Coordinator at Mission, West Virginia. I live in a little teeny tiny town called Arnoldsburg in Calhoun County, which is a huge step from where I was actually born and raised. So I lived in Akron, Ohio my whole life, and everyone that knows me knows I despise Ohio. I just can't find any good reason to be in Ohio. So I finally decided to move here in 2019. I spent pretty much my whole life coming down here to visit family, and I've always felt like West Virginia was more like home to me. So being in the state has just meant so much to me. My roots may be in Ohio, but I'm actually a West Virginia girl. So I don't like to tell people that I'm from Ohio, because they all look at me and they're like, you Ohio people can't drive. And I was like, exactly, that's why. One of the reasons why I moved, because Ohio people just, their driving's not the best. My education, I have a bachelor's and master's in social work, and I'm a licensed independent clinical social worker here in West Virginia. My previous experiences, I've worked with older adults. I've worked in addictions, corrections, and mental health. And then before I came to Mission, I was a mental health therapist for adults and teens. And then I was actually an educator at Mission, West Virginia, where I taught our healthy relationship curriculum. And then I transitioned into the youth resource coordinator. So I am the only one that does this as of now, just because we have seen a really big need for providing further services for the youth that we do serve. And I absolutely love what I do, and I love the kids that I serve. All right, so we'll go ahead and jump into eating disorders. So I always do a disclaimer. Anytime I do any type of presentation on any kind of mental health, I always add this disclaimer that this should not be used as a diagnostic tool, but for just educational purposes. And that if you are concerned about yourself or somebody else, please make sure that you're going to a licensed professional to receive the proper assessments, diagnoses, and treatment. And I think that's important, because I can remember being in grad school and I was taking psychopathology, where we were studying our DSM. If you're not familiar, the DSM is basically like the mental health Bible, where it has all the diagnostic criteria for all mental health disorders. So we would be studying mental health disorders, and my professor would say, now, as we're going through this, do not diagnose yourself or anybody else. And we're thinking like, okay, well, why would we do that? Because clearly we're not even professionals and we haven't even graduated. But I kid you not, every time we had that class, we at the end, like our eyes would be big and we are like, oh my gosh, I don't think I could be a social worker because I have bipolar and anxiety and I have all these other mental health issues and my family members are just absolutely nuts. I knew there was something wrong with them. So again, that's why I always ask, please do not use any of this to diagnose. So when we look at eating disorders, so eating disorders are behavioral conditions that are typically characterized by severe and persistent disturbances in the way that somebody eats. They're typically associated with having a lot of distressing thoughts and emotions. And sometimes these emotions can just become too overwhelming. And so it can turn into that eating disorder. Eating disorders are very serious conditions. They affect the physical body. They can also affect somebody psychologically as well as impact their social functioning. Now, we do have different types of eating disorders. Some people think when it comes to eating disorders, we basically think of anorexia and bulimia, that's part of them, but we also have other ones. So we have anorexia and bulimia and binge eating disorder. So these are the three disorders that I'm going to be focusing on because there are more, these are more common eating disorders than some of our others. So our next one is orthorexia. So orthorexia really does not have to do with self-image or the way that they view themselves. They are just very, very particular, kind of almost obsessive on the things that they eat. So they're constantly looking at calories. They're constantly looking at how much sugar or fat or carbs is in something. It's almost like this obsession with healthy eating. And so, we know that eating healthy is good for us in all aspects, but sometimes if we take it a little bit too far, it can become some type of obsession where it impacts our daily living. A lot of people that have orthorexia, not a lot, but it's very common for people to also have an obsessive compulsive disorder diagnosis as well. The next is avoidant restrictive food intake disorder. So basically people just avoid certain things of food or, like they may avoid all carbs or all sugars or different things like that. And so it can be kind of similar with anorexia, but again, kind of like orthorexia, they're not really focused or concerned about their view of their body image or self-esteem. We have other specified feeding and eating disorders. So basically, people may meet the diagnostic criteria or partially meet the diagnostic criteria for an eating disorder, but they don't meet the full criteria. But because they still have that disordered eating, there's still some eating disorder behaviors going on. So typically that would just be any eating disorder diagnosis where they don't meet that full criteria for any of the other ones. And then our last one is pica. So pica is typically when somebody eats something that has no nutritional value. If you have ever watched the TV show My Strange Addiction, there are some cases where people have pica where they may eat, I've seen people eat cigarette butts, they will eat drywall, chalk, just things that have no nutritional value that typically are not eaten. Pica is not a very, very common eating disorder, but when somebody does experience pica, it's usually associated with somebody that has been diagnosed with some type of intellectual disability, or they may be somewhere on the spectrum of autism. And we may also see this in very severe cases of schizophrenia. So when we look at the causes of eating disorders, unfortunately, there's not just one direct cause that can create eating disorders. It's kind of a combination of everything, and it creates this perfect storm. But the first is pretty common, the genetics. Typically first-degree relatives, siblings, parents that have had an eating disorder, their family members may be at risk of developing an eating disorder throughout their life as well. And this is really common with any type of mental health issue. It's just like when we go to the doctor and they want a family history of cancer and diabetes and heart failure. So the same thing goes with our mental health. If we have first-degree relatives that have been diagnosed with the mental health, doesn't mean that we're automatically going to be diagnosed with it, but it does put us at a higher risk. Our next cause is the environment. So cultural pressures, they idealize like our body is supposed to look a certain way, and it places a lot of unnecessary pressure and stress on people to reach those unrealistic standards. You know, in today's age with social media and our younger generation, everybody wants to look like a Kardashian. Everybody wants to have a big chest, a small waist, and a big bottom. And the thing is, you know, I've watched many videos of surgeons and things like that who have said to look like that or to have that type of body type does not happen naturally. So in most cases, when people have those body types, usually it's because there's been surgery or they've had fillers, Botox, liposuction, different things like that. But the thing is our younger crowds, they don't know that. You know, they just see the Kardashians working out and they think, well, if I do that and I only eat this or I don't eat that, then that's what I can look like. And so, you know, our society has placed on what beauty looks like and what the ideal body type looks like. And again, it just puts a lot of pressure on people. The next is peer pressure. So peer pressure can be a powerful force for our young people. We do know that when it comes to eating disorders and also like with suicide and self-harm, there can be a social contagion that goes on with youth when it comes to mental health disorders. And so, you know, if somebody is in high school and they know of friends that are engaging in disordered eating behaviors and they see that they're getting attention because they are looking a certain way or they're losing weight, that can pressure that other person to start engaging in those eating behaviors. And then also it can also take place as teasing or bullying. So if somebody doesn't look like what a typical, you know, teen should look like, whatever they think a person should look like, they may bully somebody, and to the point where they start having disordered eating patterns to prevent that bullying from happening. And then also our emotional health. So we do know that when it comes to eating disorders, there are some characteristics and some personality traits that if somebody does exhibit those, it puts them at a higher risk for developing an eating disorder. So we have perfectionism, that's a huge one, impulsive behavior, and difficult relationships. So all of those things that somebody experiences can lower their self-esteem and again, make them more vulnerable to developing that eating disorder. And then also research has shown that history of physical or sexual abuse can contribute to the development of an eating disorder as well. So when we think about who does this impact, really it's, you know, some people think, oh, it's just young girls, it's young Caucasian females, but that is not the truth. Eating disorders does not discriminate and can impact anybody regardless of their age, their race, gender, sexual orientation, religion, all of that stuff. There is not one thing that makes somebody you know, immune from developing an eating disorder. But when we do look at them, we know that the frequent onset of symptoms typically happens to females between the ages of 12 to 25. And adolescence is the highest risk time for development of an eating disorder because there is a lot of social pressure. It's a point in their life. They're trying to identify who they are or who they want to be. And then also, you know, just dealing with the stressors that they deal with today. So adolescence definitely is at the highest risk for an eating disorder. And in the United States, eating disorders will affect 10 million males at some point in their lifetime. But because of cultural bias and stigma, a lot of times they're less likely to seek treatment because, again, you know, society says if, you know, you are a man, then you shouldn't be dealing with eating disorders, that you shouldn't have a low self-esteem. You need to be tough and get through it. And so it's not just eating disorders, but any type of mental health issue. We do know that it can affect males, but that they are much less likely to seek that treatment. We also know that athletes can be impacted by eating disorders. And so they did a study of Division I NCAA athletes, and they found that more than 1/3 of the female athletes reported attitudes and symptoms that put them at risk for developing anorexia. And male athletes are also at risk, especially when they're in sports where they have to make certain weight requirements. And this used to really bother me because I can remember being in high school and if there were females or girls that were dealing with an eating disorder, we were deemed, psychotic or crazy or whatever. But I can remember so many of my guy friends who were on the wrestling team, and they were engaging in disordered eating behaviors, and it was okay. I can remember them binging and purging. I can remember them wearing trash bags under tracksuits, so they were constantly sweating. So, again, that's that societal thing says that if a guy does it, it's okay, but girls can't. But we know that that's not true. And then also midlife and beyond, research is showing that rates of eating disorders and body dissatisfaction occurring later on in life is on the rise. Now, they did not specify why this is, but some things that I think about is, I think social media is impacting older people because adults and older adults are on social media a lot more than they have been. And also too, with midlife and divorce. So we look at the divorce rate and it's 50%. So somebody may have been with their spouse for, a while, and then they get a divorce. And now they think, oh my gosh, I need to look a certain way if I want to get back out in the dating field and find somebody. So then they may start engaging in those eating disorders in order to look a certain way. And then the LGBTQ plus. So beginning as early as 12 years old, LGBTQ plus teens are at a higher risk of developing an eating disorder. And we also see that in a lot of research that people that are part of the LGBTQ plus are at higher risk. And a lot of that has to do with that fear of being rejected, or maybe they have been rejected because of who they are. So they are at higher risk for a lot more mental health issues than those who did not identify as part of the LGBTQ plus. So when we are looking at statistics, these can be pretty eye-opening because, we've heard of eating disorders, but a lot of times, we don't necessarily think it's like that big of a problem, but it really is. So eating disorders affect at least 9% of the population worldwide, and almost 29 million Americans will have an eating disorder in their lifetime. Now, with this one, the next one, less than 6% of people with eating disorders are medically diagnosed as underweight. And that's really important because a lot of times when we look at eating disorders or we're concerned about somebody, the first thing we want to look at, or we tend to look at, is their weight. Are they underweight? Are they very thin? But there's less than 6% are actually diagnosed as being underweight. So we can't always look at that as a way to diagnose somebody with an eating disorder. Then we have 28 to 74% are at risk for eating disorders through genetic heritability. So again, it could be a smaller percent, but it can go all the way up to 74%. And then eating disorders are the deadliest mental illness, second only to opiate overdose. And so it actually wasn't too very long ago that eating disorders were the number one that had the most fatalities of all mental health issues. But the opiate overdose and the opioid or the heroin epidemic that we're facing, those have come in first, but eating disorders are still second. And there is 10,200 deaths each year that are a direct result of an eating disorder. And so when they break that down, that's one death every 52 minutes, which is heartbreaking. About 26% of people with eating disorders will attempt suicide. And we also know that the economic cost of eating disorders is very expensive. So treating with eating disorders is almost $65 billion every year. So these are some statistics looking at youth. This is through anad.org, and these statistics absolutely broke my heart. So they looked at some elementary school age children or primary age, and they found that 42% of first through third grade girls want to be thinner. So if you can think of being back at, first, second, and third grade, I don't know if any of you maybe had thought of that, but I know from personal experience when I was that age, I didn't know like what dieting was. I wasn't familiar with that. And the way I looked really like never crossed my mind. But we can see that as time is going on and things are evolving, younger and younger girls are starting to get these ideas that they need to go on a diet and that they need to be thinner. 81% of 10-year-old children are afraid of being fat, obese, or overweight. 46% of 9 to 11-year-olds are sometimes or very often on diets. So again, when I look back at being, 9, 10, 11 years old, going on a diet was not something I ever thought of. But we're seeing that more and more often. 35 to 50% of adolescent girls engage in crash dieting, fasting, self-induced vomiting, diet pills, or abuse of laxatives. And on a college campus survey, they found 91% of the women admitted to controlling their weight through dieting. So as you see that this is impacting lots of people throughout different ages. And unfortunately, as time goes on, it seems like the younger the kids are that are starting to, kind of experience with dieting and abuse of laxatives and diet pills and things like that. So when it comes to eating disorders, it is typically a co-occurring disorder or comorbidity. So co-occurring or comorbidity is the presence of 2 or more mental health disorders. And with eating disorders, it is very, very common for somebody to also be diagnosed with another mental health disorder. And some of the more common mental health disorders with eating disorders is anxiety and depression. So those are the 2 most common. Obsessive compulsive disorder, substance use disorder, PTSD, and any other type of trauma. So when we look at, not just diagnosing, but treating, it can be very, very challenging because we're also not just working on trying to help them with that eating disorder, but we also have these other mental health disorders that are going on as well. So this is from NEDA. This is the National Eating Disorder Association. And so they did a survey on eating disorders and co-occurring. And it was crazy with, the amount of people that have been diagnosed with something other than just an eating disorder. So they had found that people that were diagnosed with anorexia, 56% of them had reported that they were diagnosed with another mental health disorder. For binge eating disorder, 79% reported being diagnosed with another mental health disorder. Bulimia, 95% of people that have been diagnosed with bulimia had also been diagnosed with another mental health disorder. So with the bulimia, out of all of the respondents that had been diagnosed with bulimia, so 64% out of that whole group actually fit the criteria for 3 or more disorders. So again, you can see how when it comes to diagnosing and treating, it can be very, very difficult and very challenging. So we're going to get into our 3 most common eating disorders. So I'm going to go over what anorexia and bulimia are, and then I'll go over some of the symptoms to be aware of. And I put those both on the same slides because it's the symptoms can actually be very similar to one another. So with anorexia, this is a life-threatening eating disorder, and its main characteristic is extreme weight loss. And they may have troubles maintaining appropriate body weight for their height, age, and stature. People with anorexia will typically restrict the number of calories that they consume and the number of food or the types of food that they eat. So less is more. The less calories they can eat in a day, the better that they think they feel. And so also with anorexia, people think that they engage in that disordered eating just by restricting their diet or their calorie intake. But people with anorexia can also engage in purging behaviors, just like with bulimia. So somebody dealing with anorexia, they may over-exercise. They may purge by self-induced vomiting, abuse of laxatives, and also binge eating. And again, anorexia has the highest mortality of any psychiatric diagnosis other than opioid use disorder. So bulimia, again, this is another potentially life-threatening eating disorder, and it has cycles of binging and then purging. And so basically when somebody is dealing with bulimia, they feel out of control and they will binge on very large amounts of food in a very, very short period of time. And then desperately, wanting to rid of those calories, or maybe they feel guilty or they feel really bad for doing that, they will purge and the purging can be from self-induced vomiting, abuse of laxatives, and excessive exercising. Now, one difference with bulimia compared to anorexia. So anorexia, we know that the people are typically underweight, or they can be underweight. Now with bulimia, people are typically of normal weight or even a little bit overweight. So again, this can be difficult to diagnose because we see someone and we think, oh, well, they're a pretty normal weight or even a little bit overweight, so they must not be dealing with any eating disorders. But with bulimia, they typically don't lose weight. Family members and friends typically may not know that they're dealing with bulimia because they don't appear underweight. And when it comes to eating disorders, people are generally very, very secretive about their eating habits and the things that they do is, such as binging and purging. So these are some emotional and behavioral things to look out for, or so that somebody may experience when they are dealing with bulimia or anorexia. So they may have that dramatic weight loss, which again is going to be more with the anorexia. They may dress in layers to hide that weight loss or to stay warm. They can be preoccupied with their weight, their food, the calories, carbs, and dieting. They may refuse to eat certain foods, so they may have these restrictions on no carbs, no sugar, different things like that. They may make comments about how they feel fat or they're overweight despite them losing a significant amount of weight. They could complain of stomach problems or digestive problems. So there could be constipation, abdominal pain, lethargy, and excess energy. They may deny feeling hungry, even though maybe you've noticed they have not eaten since the day before. And you ask them if they're hungry and they're constantly saying, no, I'm good, I'm not hungry at all. And also with eating disorders, they can develop food rituals. So they may place their foods in certain patterns or orders. They may only eat like one thing from each little section of food that they have. They may have excessive chewing, so they may think that when they're chewing, they have to chew it a certain amount of times, and they may rearrange food on their plate. And so these food rituals can definitely be tied to somebody that is dealing with some obsessive compulsive tendencies. So that's where those food rituals come from. They may cook meals for other people, but they never eat it themselves. They may feel ineffective or have a strong need for control. They may make excuses to avoid mealtime or any type of situation involving food. So a common excuse is, I don't feel good, or my stomach hurts. Those are very common excuses that, when somebody's trying to avoid eating. They express a need to burn off any calories they take in, even if it was something considerably low. Maybe they ate something that was 100 calories and, they are starting to express some stress and anxiety about them needing to get rid of those calories. They have an excessive rigid exercise regimen. Despite any time they maybe feel tired or if they're sick, they will still engage in that excessive exercise. They can withdraw from their friends and activities. They can become more isolated. And that's really because when it comes to eating disorders, I had mentioned earlier, people are very secretive about these eating disorders. They may seem embarrassed or concerned about eating in public. They have limited social spontaneity. So they're just kind of, they like structure. They may resist or they're unable to maintain a body weight that's appropriate for who they are. Have an intense fear of weight gain, even if they are underweight. They may have disturbed experience of body weight or shape and, constantly looking at themselves and beating themselves up because they don't like who they are. They don't like how they look. So they're constantly attacking themselves. And then for post-puberty females, they can lose their menstrual period. So they call that amenorrhea, and that's the absence of a menstrual period. And a lot of times that could be from an eating disorder, but that can also be common in young females that are very athletic. So again, just because something, is screwed up with that menstrual period, it doesn't always mean it's an eating disorder. It could be some other reasons, but that can be common for an eating disorder. So some of our physical symptoms when it comes to anorexia and bulimia. So I mentioned earlier the stomach issues, cramping, Gastro complaints, constipation, acid reflux can be very common. They can have difficulties concentrating. And really that could be for lots of reasons, whether they're stressed about the calories they've consumed or if their body is hungry. I don't know if any of you experience this, but I know when I'm really hungry and I can't eat right then, I always call it hangry. So I'm like kind of cranky and irritable at the same time because my body's like, girl, you need to eat something. And so it can also lead to troubles concentrating. If they go to a doctor to have blood work done, there can also be some abnormal lab findings. So they could have shown to be anemic, and that can cause that fatigue, low thyroid and hormone levels, low potassium, low blood cell counts, and slow heart rate. They can also experience dizziness and fainting or syncope. They may feel cold all the time, and a lot of that can be if they're underweight. They can have trouble sleeping, menstrual irregularities, which I just talked about. For purging by self-induced vomiting, some people may have cuts or some scars or some scabs or calluses across their knuckles, and that is a result from induced vomiting. There's also lots of dental problems that can come with eating disorders. So there could be enamel erosion, cavities, tooth sensitivity, and a lot of that can happen with binging and purging. So with the purging, when your mouth is constantly being exposed to those acids, when you're purging, it's going to erode the enamel on your teeth. And for some people, if they don't get that treated, essentially can lead to tooth loss. They can also have dry skin, dry and brittle nails. Their salivary glands can swell up, and that's just from that induced vomiting. They can produce fine hair on their body. So they call this lanugo. And to me, this just shows how amazing our bodies can be. So basically what can happen with an eating disorder is their body temperature could be of below normal, especially if they're very underweight. And so basically your body will try to make up for that and start producing all of this fine hair all over the body in order to try to regulate that body temperature or to try to bring some of that temperature back up. Their hair can thin, become dry and brittle, and some people, I know they've had hair that have fallen out. Cavities and discoloration of teeth from vomiting, muscle weakness. Yellow skin can be common, and basically that's really from eating large amounts of carrots. So when we look at eating disorders, carrots seem to be a very common and popular food to eat because there's really no fat, there's hardly any calories on there. And so somebody would have to eat a very, very large amount of carrots for a long period of time before they can start producing, like some of that melanin from that carrot can essentially change their skin to look kind of jaundice. They could have cold mottled hands and feet or swelling of their feet, and that is caused basically from the binging and purging. And so, when you're purging, your body can start producing extra fluids in order to try to make up for everything that is being purged. So that can lead to those mottled hands and feet and also the swelling. If there's any wounds, it can be very difficult for them to heal. And basically that's because when it comes to eating disorders and not getting that nutrition the body needs, their immune system is not going to be very good. So any wounds can take forever to heal. And they may find themselves being sick a lot more often because their body just is unable to fight against any illnesses. And then our last is binge eating disorder. So binge eating disorder can potentially be life-threatening and treatable. But basically, this is characterized by recurrent episodes of eating large amounts of food in a very, very, very short period of time. And oftentimes people, when they binge, it'll quickly get to the point where they're very uncomfortable because they're so full. So what can happen is they feel that loss of control during their binge. And it's kind of like this vicious cycle, if you will. So they may have these really strong emotions. They're not sure how to control it other than binge eating. So they'll binge eat. Once they binge eat, they start to feel embarrassed, guilty, or shame of their behaviors. And then in a way to cope with those, they will binge again. So that whole cycle will just repeat itself. Binge eating disorder is actually the most common eating disorder in the United States. And what's really cool is not too long ago, binge eating disorder was not recognized in the Diagnostic Statistical Manual, or the DSM, that I had mentioned earlier. So in 2013, they finally made it its own diagnoses, which is great, because if you had a mental health diagnosis that wasn't in the DSM and didn't have that billing code, then most insurances would not cover the cost for any type of treatment. So the fact that they were able to make it its own diagnosis and give it that billing code now allows for so many people to get that treatment that's typically will be covered by insurance. So some of our emotional and behavioral patterns and behaviors that come with binge eating. So that could be the disappearance of large amounts of food in a short period of time. It can be very common to find empty wrappers or boxes hidden somewhere strange in the house, or even like you might find large amounts of food being hidden somewhere. Like I was working with a teenager and that was dealing with bulimia. And what brought mom's attention is something was going on with the toilet. And when she took the back lid off of it, she found tons of food wrappers that were hiding in that. And so, that can be common not just with binge eating disorder, but also bulimia, where they will hide those wrappers or also store and hoard large amounts of food in an unusual place. They may be uncomfortable eating around others. They may practice any fad diets or cut out a whole bunch of food groups, or may become a vegetarian or vegan. They may have fear of eating in public, or they'll steal or hoard food in strange places, like I mentioned. They'll create those lifestyle schedules to make time for their binge sessions, because again, to them, this isn't something that they're going to do in public or that they want people to know. So they're going to work this around their schedules so other people are not aware of what's going on. They may withdraw from their friends and activities, frequently diet, show extreme concern with body weight and shape. They may check in their mirror and point out all of their flaws and everything they don't like about themselves. They may have secret recurring episodes of binge eating. And again, a lot of it has to do with this lack of control. There can be disruption in normal eating behaviors, including eating throughout the day with no planned meal times, skipping meals, taking small portions of food, engaging in sporadic fasting or repetitive dieting. So some people are very strict on, having this regimen that they eat breakfast, lunch, and dinner. Everybody has those, but when it comes to binge eating, they really have no normal eating patterns. It's basically they're in that survival mode for that day. Whatever they can do to try to get through the day, that's what they're going to do. They may be afraid to eat alone, or they eat alone out of embarrassment because of the quantity of food being eaten. And, again, it comes from that lack of control. So they don't want people to see how they eat. So they may feel embarrassed and eat alone often. They may have feelings of disgust, depression, or guilt after overeating, and feelings of low self-esteem. So some physical symptoms, we have fluctuations in their weight, both up and down. So they're not typically at a stable weight for long periods of time. So they may be normal weight. The next, they may be a little bit overweight. The next time they could be underweight. So their body weight is typically fluctuating all the time. They can also have stomach cramps and gastro problems such as constipation, acid reflux, heartburn, difficulties concentrating. And then this is really interesting. So most people who are labeled clinically obese do not have binge eating disorder. Some people think that if a person is overweight or obese, it's like, oh, well, they must binge eat, but that's not the case. But however, people that have binge eating disorder, up to 2/3 are labeled clinically obese. And people who struggle with binge eating tend to be of normal or higher than average weight, even though binge eating disorder can be diagnosed at any weight. It doesn't mean you have to meet certain weight requirements to be diagnosed with any type of eating disorder. So when we look at eating disorders and social media and the internet, we know that our youth go to the internet for everything. They get all of their answers from TikTok and Google. That's how they're educating themselves. And when we look at eating disorders, there are some websites that can provide a lot of really great information, referrals, and resources. And I'll talk about those at the end. But there are also websites and social medias that promote eating disorders. And so these are typically called thinspo or thinspiration. You will hear people that are engaging in eating disorders. They may talk about pro Mia or pro Anna, or they may talk about, I met a new friend, her name's Mia, or I met a new friend named Anna. And again, that's their way of keeping that secretive. But these pro Mia and pro Anna websites are extremely harmful to anybody that could be triggered to engage in an eating disorder or already have one. So when we look at these Thinspiration websites, so basically what they're doing is they are encouraging people to continue to engage in their eating disorder. So they will provide tricks and tips on how to hide their eating disorder. There's ways of, what you can do if you're starving, how you can get through that hunger crave, how to self-induced vomiting without making any noise so people can hear you. So again, it's all about continuing that eating disorder, which we know is very harmful and detrimental. Now, when people do create these pro Mia and pro Anna content, some people will create these websites as for it to be a support center to help people to work through those eating disorders. And they typically mean well, but you still have to be careful of these Thinspiration websites that is, allowing people to continue engaging in their eating disorder. The other thing is if they're looking at these support groups or, these websites, even though they may not have these Thinspiration things on there, some of these websites can still be harmful to somebody that has an eating disorder or vulnerable to developing one. And a lot of that has to do is they may feel more negative about themselves. We can see that with like if we're looking up like eating disorders and, and it talks about like the things that those people experience, or maybe they're having suicidal thoughts, or, they still struggle even though they have been in recovery for 10 years. So it can create more negative emotions about themselves and their environment. It can damage feelings of competitiveness. So that's more of the Thinspiration websites. So they see somebody that is dealing with anorexia and they're very underweight. So the person seeing that says, well, I'm going to one up them and I'm going to weigh less than they are, and I'm going to look more thin than they are. And it also pushes people to setting these unhealthy and unrealistic goals for themselves. And again, a lot of that can be from their self-view of wanting to look a certain way. So some of these websites basically, that are encouraging people to engage in those eating disorders, basically they're telling these people that their eating disorder is a choice and not because they have this mental illness or that they're sick. And so again, if somebody is trying to help them get into treatment, they're going to be less likely to engage in that because they're telling themselves, no, I'm choosing to do this. If I want to sit down and eat, I can do that. But I want to look thin. I want to look this way. And we know that that's not the case when it comes to eating disorders. It's definitely not a choice. There definitely is a sickness that is going on with them. And so again, it can make it more difficult for them to break away from those eating behaviors and less likely to get into treatment. And just like pretty much all other mental health disorders, we know the longer that somebody waits to get into treatment and to get help, the more challenging and more difficult it is to get away from those behaviors and to start that recovery process. So it's always important for people, when they're dealing with any type of mental health disorder, that they're engaging in treatment sooner than later. So this is just a little disclaimer. These are some pictures and quotes that I found online and social media that are very harmful and damaging to people that may be engaging in eating disorders or vulnerable to developing one. So we can see in the upper left-hand corner, these are some two TikTok accounts. So we have this, this inspiration. We have a female hair in the sports bra and sweatpants who is very fit and thin looking, talking about, how to lose weight. So it's just drinking water, ditching sugar, eat spicy foods, stay away from processed foods, which I get, processed foods we know is not healthy, but when somebody is vulnerable to developing that eating disorder, they can take these things to a whole new extreme. Then the one next to that, we have a person there that's exposing their chest bones, and that's from their weight loss, from anorexia. Underneath Instagram, this is an account called Anorexic Bones. So basically, it's just showing off their bodies from dealing with anorexia. So it's, a person being able to put their hands around their thigh, or, they can almost get their hands around their waist, different things like that. And then the website at the top that says Anorexic Nation. So this is an example of a Thinspiration or a pro-Mia or pro-Anna website where they glorify eating disorder. So as you can see, there's a picture of a person on there who is extremely underweight, and it says perfection, beautiful, and glorifying. So, over on the side, it says Anna and Mia. So you can go and click on, if somebody's experiencing with anorexia, they can go to the Anna section where they can get all of those tricks and tips on how to continue their eating disorder, as well as talk with other people online. Underneath that, so I always looked at Pinterest as being like a safe, social media place, but it's not. It's not. I've just come to learn that there's nothing on social media that is going to be always safe. So with Pinterest, they have these quotes, that can kind of go along with that inspiration. So nothing tastes as skinny feels. Work hard, eat clean. Talk dirty. Do not give up what you want most for what you want at the moment. And it shows somebody that's, very thin. So again, these can also be looked at as inspirations and something that allows a person to continue with their eating disorder. And then the next and last one, that perfect thigh gap. So this was very popular a couple of years ago. If you didn't have a thigh gap, then you weren't anybody. So there was lots of things on social media about how to get that thigh gap, and come to find out that it's almost impossible to get that thigh gap, by squatting and jumping jacks and doing these exercises, because our bodies are made up differently, and somebody can still be underweight, but they may not have that thigh gap. So when somebody sees get that perfect thigh gap, they're going to do all these exercises and they're going to do it for a long time. And when they see that they're not developing that thigh gap that everybody says that they have to have, they're going to go to other extreme measures to try to get that. So we know that the internet and social media, it can be great for lots of things, but we also have to be cautious, especially when it comes to our youth, because they are turning to the internet and social media to learn and find out all of the answers for everything, and we know that just because it's online doesn't mean that it's real, but a lot of our young people don't know that. So next is my personal story. If you guys attended my first eating disorder webinar, I talked about my personal story, and I'm just going to share it again in case there's some new people on here. But this is a reason why, when it comes to mental health and eating disorders, why I have such a huge passion for it. But I battled bulimia throughout high school and a little bit into college. And so when it came to my eating disorder, when I started learning more about eating disorders, I was getting really frustrated because, everything I was reading, the DSM and online, they said, well, it's an eating disorder because you don't like how you look, or you have a negative view of your body. And it all had to do with my self-image. And it would make me really angry because my eating disorder had nothing to do with any of that. When I started engaging in my eating disorder, I was 105 pounds. I'm only 5'1". I'm very short. And my eating disorder was really my way of coping. It had nothing to do with weight. It had nothing to do with my body. It was my way of coping. It was trying to cope from years of childhood trauma and feeling like I had this loss of control in my life. And so the only thing that I could do to control that was I could control what I ate, but I could also control by purging. And so, it just kind of became this addiction to me and my way of coping. It's very similar, though my way of thinking was very similar, like to somebody who self-harms, someone who may cut themselves. And I actually, me and my husband talk about this all the time, and he's always given me permission to share, but he's a recovering alcoholic. And so we've always talked about how our ways of thinking were so similar. It's just the way that we coped was different. But the backstory and the reasons why we were engaging in those behaviors was pretty similar. We had these very strong, intense emotions, and we had no idea how to cope with them. So we found these unhealthy ways of coping, which we know now was not a great idea. But with my bulimia, it was my best friend, and it was the one thing I could count on. My bulimia was there for me when I was sad, when I was angry, when I was stressed, anxious. If I was having a good day, if I was feeling really good, it didn't matter. That person or that eating disorder was always there for me. And, it took me a while to realize that maybe this probably wasn't the most healthiest way, but number one, I was young, I was a teenager. And number two, when I would have my purging episodes, I felt a very, very strong euphoria from those purging episodes. It was almost like my way of releasing those emotions. It was like a high almost. And it was something that I never wanted to give up, because as long as I was able to do that, I could still function in all of my different environments. I could still function at home, at school, with my friends and different things like that. So, after doing that for some time, you eventually get to a point where you become sick and tired of being sick and tired. But again, you feel stuck. You have this constant battle in your head of, don't do this, don't binge and purge, don't binge and purge, which would create a lot of anxiety and stress. And then before I knew it, I was binging and purging. It wasn't too long, about maybe 2 years before when I started doing that it really started affecting all aspects of my life. So my grades were slipping. I excelled really well in elementary school, and in high school, I wasn't like a straight A student, but I basically had no motivation to do anything. I really could care less. I started isolating myself more. I no longer wanted to be around with my friends or my family. I started lying all the time. My lying was basically just a way to get out of the house so I could binge and purge. So it would be, hey, mom and dad, I'm going to go with so-and-so. We're going to go see this movie. And they would never think twice about it. So little did they know, I never went and saw that movie. And I actually never even saw that friend. I would drive around and I would engage. I would go get food, and then I would find somewhere, go to a park, somewhere that there was nobody around, and I would purge. So that was my way of coping for quite some time, until my later years in high school. Friends found out about my eating disorder and were a little concerned about it. So when I would go to binge and purge, there was a bathroom by the gym of our school, and I always went to that bathroom because there was only one toilet. It was just a one-person bathroom, so nobody else could be in there. So I went in there after lunch, just like I did every day, and when I opened the door, there was the hall monitor. The hall monitor took me to the principal's office, and I was playing stupid. You have to remember that when we are being confronted, especially something that is because my way of coping, I'm going to be manipulative and I'm going to play dumb and all of those things. So my principal was talking to me. I told her that all my friends were lying. I had explained that I was recently put on an antidepressant, which I was because I was diagnosed with depression and anxiety, and that it just made my stomach upset. So we just talked for a bit and I left, pretend like everything was fine. And then I got home. And when I got home, my mom was on the phone and she had been crying. I knew exactly why she had been crying, but I wasn't going to say anything. So I just I was like, oh, are you okay? And she's like, I had a long day at work and I played dumb. I was like, great, that's awesome. Now I can keep doing what I need to do. But I knew better. I knew that she had known that the principal had called her. And it's because anytime we would eat, my mom and dad, man, their eyes were like lasers, like going through my head. They were keeping a close eye on me anytime I would eat. If I would go to the bathroom, I would be in there for maybe 15 seconds and they were already knocking on the door. Autumn, is everything okay? Are you all right? And unfortunately, I was getting really angry. I was getting really annoyed and aggravated. And I knew that they wanted to say something, but I wasn't going to put up with that because I didn't want that to be taken away from me. And so it was probably about a week that had gone by of them acting this way. And they finally just sat down and they were like, we need to talk. And so at first, I was very angry. I pretty much put everything back on my mom and dad. I was saying they were the ones with problems, that they obviously had nothing else better to do than to stalk my every move. I was not a very pleasant person. And I'm so grateful, though, that my parents didn't give up. This was the first time they had ever had to deal with something like this. And, when there's not a manual that comes with being a parent that if your child experiences, this is what you need to do. So I am very grateful that they stood their ground and they still they would not let me leave. And we were talking about it. And it just finally, I got to a point I broke down. It was at a point where I felt I was at my lowest. I had no motivation. I had no will left to live. I definitely had suicidal thoughts because at that time I figured if I wasn't alive, I wasn't feeling. And that's all I wanted to do. I didn't want to feel anymore, especially if they were going to try to take that eating disorder away from me. So because of all of that, the very next morning, I was sent to the hospital and I was admitted and I spent over a month there. And the problem with that is where I lived, we did not have anything that was specialized for eating disorders. We did have a program at the Children's Hospital, but because I was 18, I was not eligible for that program. So I basically spent over a month in a psychiatric unit where I got cookie cutter treatment for the same reasons that, people were there for schizophrenia, having severe delusions, hallucinations, people that severely self-harmed. I can remember people had arms, they had gauze wrapped all up and down their arms. It just wasn't effective treatment. And, I was angry because anytime I would eat, I had to be monitored. And then they would have a nurse or somebody sit with me for at least 45 minutes because with bulimia, somebody that's engaging that eating disorder knows that if you are going to binge and purge, it's best to try to purge within 30 minutes after eating. Otherwise, purging is a little bit more difficult. So they would sit there and ask if I, had those urges. And I was, very hateful. I feel really bad if I could go back and, write them an apology letter. I just was not a very pleasant patient, but, I was angry because, again, they were taking the one thing that meant the most to me. They were trying to take that away. So I got out of the hospital and because I had been stabilized. Now I wasn't in a recovery because basically they were just trying to get me stabilized and I had no follow-up. They did not refer me anywhere. They just said, just go to this doctor to have them monitor your medications. And I don't know what they were expecting, but I did not end my eating disorder there because I didn't know how to. I really didn't learn anything when I was in the hospital. So I, continued to engage in my eating disorder into my first year of college. And then, my first year of college, I'm away from home. And so I started replacing that with alcohol. So I started partying as a way of coping. But it finally got to a point where I just kind of did my own research. I did my own self-help. And I was able to get into that recovery, and it was not easy. And that's why we call it a recovery, because at any point relapse can happen. So it's like you have to keep yourself in check on a day-to-day basis, because, it could be the drop of a dime and somebody can go back into whatever unhealthy way of coping that they were doing. So I have been in recovery for about 15 years. And that's why, when it comes to eating disorders, it's just a very huge passion for me. Especially because so many people suffer from it. And I feel like we have very, very little resources for those that are engaging in those eating disorders. When we look at inpatient treatment centers for eating disorders, they're not in every state. A lot of times people have to go out of state, and they are expensive, like tens of thousands of dollars each month. And if you're lucky for insurance to cover that, that's amazing. A lot of insurance don't. So I've always just wanted to create and have more of those resources available, because like I had mentioned, I struggled significantly, with my eating disorder, because I really didn't get any treatment, but I did when I was older, and I realized that I needed to make changes. I put myself into therapy, and that was also, another huge contribution to my recovery. So that's why, eating disorders is such a passion for me, and just mental health in general, because honestly, we all have a story. And if we don't necessarily have a story, we know somebody who does. Mental health impacts so many people.
Hey, Autumn,
Yeah.
we have a question in the log. Do you want to address that before you move forward?
Sure, let me look at it.
I can read it to you if you want. It's this person is an autistic adult, and they have sensory issues. States that they've always been extremely naturally thin, as well as having an underactive thyroid. They're losing a lot of weight, and no matter what they eat, they can't gain weight. Wanting to know if you have any advice. They're currently, it looks like they may be British. I didn't know what 6 stone was. I Googled that. That's approximately 84 pounds. And they feel like they have low self-esteem due to it.
Sure. So with that, it's going to be important to talk with a doctor about that. Now I see you have an underactive thyroid, typically, and it's kind of, I'm trying to think of the word, but usually with an underactive thyroid, they're typically, I thought it was overactive thyroid, that there was weight loss involved with that. But for some people, like they just have a really hard time gaining weight and maintaining that weight. And that can be really difficult for them as well, because I had a friend who was extremely thin, but she didn't have an eating disorder, but people always accused her of being anorexic because of the way that she looked. But my advice would be to speak with the doctor just to make sure they've done all testing to rule out any other causes for weight loss, because there are lots of things that can cause weight loss. And if that all works out, I would definitely seek, to look for a nutritionist, and they can tell you what kind of diet maybe you need to eat. Like maybe you need to eat more protein or more carbs, different thing like that. But I would definitely look at, first going to the doctor and also seeing a nutritionist, because from how I read that, it doesn't sound like that you are engaging in an eating disorder. So it just could be that you're just naturally thin. But, because you are losing weight without trying, then I would definitely talk to those medical professionals just to make sure everything is okay. And also a nutritionist to see if there's a specialized diet that you can, that you should be eating in order to try to help gain some of that weight. So thank you for that.
Thanks, Autumn.
You're welcome. Okay. So when we look at diagnostic criteria, again, people usually have to meet this criteria in order for insurance to approve for treatment. Now, what's really cool is they have the eating disorders not otherwise specified. Well, that was the old one that they have. So, if somebody doesn't meet the full criteria, but they still have those patterns of disordered eating, then they can go into that other diagnosis so they can still get that treatment. But this is the criteria from the DSM that can diagnose somebody with anorexia. So the first criteria is that they have a restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, development trajectory, and physical health. The next is that they have this intense fear of gaining weight or becoming fat, even though they appear underweight. And then also with C, the disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or denial of the seriousness of their current low body weight. And so basically all these behaviors and thoughts, typically they have to be persistent for the last 3 months in order for somebody to meet that criteria for anorexia. Now for bulimia, bulimia criteria gets a little bit more in depth. So the first is that they have these recurrent episodes of binge eating. And again, binge eating looks or is characterized by eating in a large amounts of food in a very, very short period of time. And then also feeling that sense of lack of control over eating during their episode. So they feel that they can't stop eating or control what or how much one is eating. The next criteria is that they have recurrent inappropriate compensatory behaviors to prevent that weight gain or using it as a coping mechanism. So again, that would be the self-induced vomiting, the misuse of laxatives, diuretics, diet pills, or any other type of medication, engaging in fasting behavior, or also having excessive exercising. The next is that binge eating and inappropriate compensatory behaviors both occur on average at least once a week for the last 3 months. And the DSM also has, like mild, moderate, and severe. So depending on how often somebody engages in binging and purging, then that would determine the severity of their eating disorder. Self-evaluation is unduly influenced by body shape and weight, which I don't agree with that because that was not my case. And then the disturbance does not occur exclusively during episodes of anorexia. So again, somebody that has been diagnosed with anorexia can still have binge and purge behaviors, but it doesn't necessarily mean that they're being diagnosed with bulimia. They still just have that anorexia diagnoses. And then for binge eating disorder, so they have recurrent episodes of binge eating. And again, that binge is eating in a short period of time with large amounts of food, and that lack of control over eating during their episode. And that these binge eating episodes are associated with 3 or more of the following. So they're eating much more rapidly than normal. They're eating until they're feeling uncomfortably full. Which I've had that before. I don't know if any of you I've had times where I've eaten so much, I feel like I can't catch my breath. It was very uncomfortable. And eating large amounts of food when they physically are not hungry. And then eating alone because of feeling embarrassed by how much they're eating, or feeling disgusted with themselves, depressed, or guilty after they have these binge episodes. They can also have marked distress regarding their binge eating. So there's always that stress of their binge eating episodes that is going on. The binge eating occurs at least once a week for 3 months. And that binge eating is not associated with the recurrent use of inappropriate compensatory behaviors, so purging, as in bulimia, and does not occur exclusively during the course of bulimia or anorexia. So basically, when they put those with the diagnostic criteria, it's basically just saying that they're not engaging in other, behaviors of eating disorders that may qualify them as having bulimia or anorexia. So when we look at treatment for eating disorders, treating eating disorders can be very, very challenging. And it's not an easy road, and it's not short term. It isn't something that a person can go to therapy for 2 weeks and they're magically cured. If that was available, man, that person would be rich. But that's just not how it works. And we also know that the sooner a person can get into treatment, the higher chance they have for that recovery. So it's basically like any type of unhealthy coping skill. We know that if somebody is coping by using drugs and alcohol, well, the longer they engage in those behaviors, they can form that addiction, that physical addiction. So it makes it more difficult for them to get into treatment. And I feel like with eating disorders, there is somewhat of that physical addiction to it, to those behaviors and those feelings and emotions when somebody is engaging in that. But there are lots of different therapies that have been shown to be super effective in treating eating disorders. So our first is cognitive behavior therapy, or CBT. This is a very, very common therapy that people use. Dialectical behavior therapy, or DBT, is another very common and popular therapy method with eating disorders. We have acceptance and commitment therapy, or ACT. We have trauma-focused cognitive behavior therapy. So TFCBT is recommended for kids and adolescents. So this can be helpful if a youth is engaging in eating disorders that may have stemmed from trauma that they have experienced. And so they're using their eating disorder as a way of cope. So if, we're not addressing those issues from that trauma, then it can be really hard for them to recover from that eating disorder. And I took a 2-day in-person training in Parkersburg on TFCBT. It was put on by Harmony Mental Health in Parkersburg. It was one of the best 2-day trainings that I have ever been to. It's just a really, really awesome therapy. And it's not highly crazy and difficult to do. So I know I just got an email that they're doing one in November, but it's virtual. So if you have a chance to attend that training, I highly recommend it. We have interpersonal therapy, so IBT. Interpersonal therapy is basically just taking a look at those interpersonal relationships and how that impacts your mental health. And then we have family-based therapy. Again, that one's recommended for kids and adolescents, and the list goes on and on. There are lots of really great therapies out there for treatment, but I'm going to focus on the top 3, which is CBT, DBT, and ACT, as these are some of the more common therapies that are used for eating disorders. So when we look at cognitive behavioral therapy, this is a short-term, present-oriented therapy, and it's directed towards solving current problems and modifying those dysfunctional behaviors and those unhelpful thinking patterns. So basically what they have found is that the way we think, it connects to our feelings, and then our feelings connect to our behavior. So all of those they kind of all relate to one another. And so if we are able to help with those unhelpful thinking habits or those behaviors, then we can start to decrease on those behaviors of our disordered eating. They have found CBT can treat lots of mental health issues such as depression, anxiety, substance use disorder, eating disorders, and severe mental illness. So, somebody that has schizophrenia or any other type of psychosis, this can actually be effective as well. And research has also shown CBT actually produces change. So when we are going to treat or help somebody with an eating disorder or any mental health, we want to use something that's going to work, that can be effective, that is shown to help people. So CBT is one of those that has been shown to be effective for lots of different issues. This is a very, very popular treatment, and it's just as effective, if not more effective, than other forms of psychological therapy or psychiatric medication. So we know that psychiatric medications can be very, very helpful, especially when it's more about stabilizing those mental health symptoms, but we know that medications are not a cure-all. I always tell people that I've worked with that there's no magic pill that's going to fix that. If there was, we would all be taking that magic pill because we all go through things in life, and I probably wouldn't have a job because we all would be dealing with life normally and functioning just well. So not that I'm glad that we have mental health disorders, but a lot of times when it comes to mental health, especially eating disorders, it takes a lot more than just medication for them to reach that recovery. So CBT also, they have core principles. So some of the principles that they identify is that our psychological problems are based in part on faulty or unhelpful ways of thinking. So we have found that our own brain can be our worst enemy when it comes to mental health and trying to cope and trying to recover and trying to feel better. We are really good at beating ourselves up all the time. And I'm not sure why that is, and I'm guilty of it. We all do it, but we know that sometimes our brains are not always the smartest when we need them to be. Another core principle is that psychological problems are based in part on learned patterns of unhelpful behaviors. So another thing is if somebody has grown up in an environment and this is how they've seen people cope, or they have said those things to themselves, then that's what we're going to learn. And essentially that's what we are going to do as a way of coping, although we know it's not necessarily helpful. And that people suffering from psychological problems can learn better ways of coping, thereby relieving their symptoms and becoming more effective in their life. So again, if we can work on tuning down these negative thoughts, that is going to produce more positive feelings and more positive behaviors. So that's kind of the whole goal when it comes to cognitive behavior therapy. So they have different aspects and pieces and parts with CBT. So the first is changing those thinking patterns. So it helps us to recognize that our thinking distortions are creating those problems. And then we try to reevaluate them in the light of reality. So for example, like I have students that'll say, well, I can't do this because if I do this, then this is going to happen and that's going to happen and my whole life is going to fall apart. And I'll say, what's your proof? What do you have that proves that that's what's going to happen? And they're like, oh, well, I don't. And I'm like, exactly. So with CBT, it helps us to realize that the way we think doesn't always necessarily mean that that's what is going to happen. So sometimes we have to reevaluate those thoughts and really think about what the reality is. Now, is that actually going to happen if I do this? Probably not. So what is something more true that is likely to happen if I do A, B, and C versus what I'm telling myself is going to happen? It also helps people gain a better understanding of their behavior and motivation of others. So sometimes our thoughts and our feelings can produce these behaviors that are not typical of us. Sometimes we look back and say, well, why did I do that? So when we ask ourselves the why, then we're going to say, oh, because I'm an idiot, or I'm not smart, or I'm mentally ill. So then we start with those thoughts of, well, if I'm mentally ill and I'm not smart, I'm never going to do anything with my life. So you can see how there's just this pattern of where we put one thing in our brain and we can grow it into something huge and completely allow it to tear us down when we have no proof. It also helps with problem-solving skills to cope with difficult situations, because we know when we're having a difficult situation, we will find the easiest and effective way that we find to be a healthy way of coping. So for me, it was binging and purging. For some people, it's alcohol or drugs. For other people, it's punching the wall, whatever it is. So CBT allows people to find and learn new problem-solving skills that are in a more healthy way. And then that also helps them learn to develop a greater sense of confidence in their own abilities. Because again, especially with eating disorders, we're not, we aren't bragging about how awesome we are. If anything, we will be the first person to be like, I totally suck. Even though that's not the truth, but, we just beat ourselves down. CBT also looks at changing behavior patterns. So sometimes if a person has a fear, they will avoid it. And when it comes to CBT, we really don't want people to avoid those fears because, those fears can actually continue our eating disorder or whatever mental health disorder we're dealing with. So CBT helps people to face their fears instead of avoiding them. They also have activities such as role playing, and this helps people prepare for problematic interactions with others, because we also know that relationships, whether it's people we go to school with, we live with, somebody we're dating, whoever, those relationships can actually play a huge role in somebody continuing their eating disorder. And then it also looks at using mindfulness. Mindfulness is amazing, and it helps people to calm their mind and relax their body. So we know that when our mind is calm and our body is relaxed, we're going to be thinking a little bit more clearer than if our brain was filled with all of those unhelpful negative thoughts. And then I just put a note down here that when people are doing CBT, there are lots of different pieces and parts and activities, and not all CBT will use all of these strategies, but basically the therapist and the patient or client are going to work together and figure out what is going to be the best way of treatment, and then come up with that treatment plan to determine what parts of CBT could be beneficial and more effective than some others. So some CBT resources, this on the left-hand side, Cognitive Behavior Therapy Basics and Beyond. This is a book that I had to read. I took a CBT course when I was in grad school, and this is one of the books that I recommend. So this was written by Judith Beck and Aaron Beck. So Aaron is kind of the father of CBT, and Judith Beck is his daughter. So she's also very big into CBT. So this is a book I recommend if you want to learn more about CBT and how you can utilize it in therapy and with people. That's one that I recommend. The BeckInstitute.org, therapistaid.com, thinkcbt.com, apa.org, and Psych Central. All of these websites have lots of resources, lots of handouts. Therapistaid.com, if any of you have ever been on that, they have hundreds of free worksheets and handouts to give to people for different types of mental health disorders, and also different therapies. So they have worksheets on CBT. They also have ones on DBT. So these are all really great resources if you are wanting to learn more information about CBT, or also maybe get some resources that you could utilize with the people that you serve. Our next therapy is dialectical behavior therapy. So I love DBT. This is actually a branch off of CBT, and it was initially created for borderline personality disorder. And what I love about DBT, the author and creator of DBT is Marsha Linehan, and she created DBT specifically for those with borderline disorder or personality disorder, and who self-harmed and were high risk for suicidal thoughts. And what's really cool about Marsha Linehan and why I love her therapy, so she herself has been diagnosed with borderline personality disorder as well as other mental health disorders. She has shared her stories of having psychosis and having to be hospitalized, and being, self-harming and having suicidal thoughts. So, she has lived, the things that she talks about. And so once they first, started doing more research on that DBT, they have found that DBT is pretty much effective for any type of mental health issue. So it's effective for those struggling with attention deficit disorder or attention deficit hyperactivity disorder, bipolar, other mood disorders, borderline personality disorder, or any other personality disorders that would be on that axis too, eating disorders, general anxiety disorders, major depressive disorder. NSSI is non-suicidal self-injury. So this is another term that people will use for self-harm. Obsessive compulsive disorder, post-traumatic stress, substance use disorder, suicidal behavior. So again, DBT is a very, very great therapy. And again, it can be very effective for lots of different issues. So they have 4 main goals. There's 4 sections that are part of DBT, and they teach people how to live in the moment. So they help them with that whole being mindful and being in the present moment. It helps them develop healthy ways to cope with stress, because again, when we look at mental health, and especially eating disorders, we use that, or we can use those eating disorders as a way of coping, and we know that's not healthy. It also helps people to regulate their emotions and improve relationships with other people. So this is our, whoops, sorry. So this is our first DBT skill that they talk about, the core mindfulness. So this is the section that helps people develop those mindfulness skills and to help them understand what mindfulness is. It helps them to be present or to that live in the moment. It helps them to pay attention what's happening inside of them. So it allows them to pay more attention to their thoughts, their feelings, the senses that they're experiencing, and their impulses. And it allows us to use our senses to tune in and focus on what's happening around you. So again, when we have like the whole mindfulness thing going on and we're more aware, I feel like we feel like we have more control over our own selves, our own thoughts, and our own feelings. So that's why teaching that core mindfulness is so important, because if we feel like we have a sense of control, that can also be helpful in trying to decrease some of those patterns of eating disorders. So they talk about what you see, smell, hear, touch, and taste in non-judgmental ways. They have like there's a grounding technique. It's the 5, 4, 3, 2, 1. So you use your senses to kind of help calm yourself down and bring yourself in that moment. So it helps you to slow down mentally and emotionally and focus on healthy ways of coping when we are experiencing that emotional pain. So it's allowing us to learn those healthy ways rather than binging and purging or restricting calories or just binging. Mindfulness can also help us stay calm and avoid engaging in automatic negative thought patterns and impulsive behaviors. So again, when we have a calm mind, then we're able to think more clearly. We're able to think about, okay, if I do this, what are the possible consequences of me coping in an unhealthy way? But when we're calm, we're able to just see all of that. But when we have these intense, erratic emotions and thoughts going on in our head, it becomes so overwhelming that we're just going to reach out to the first thing that we know is going to help us to calm down. And if somebody has an eating disorder, it's going to be one of those. So the next section of DBT is distress tolerance. So distress tolerance, and they look at the whole radical acceptance. This is something I've always struggled with. I still struggle with radical acceptance. And I think it can be a common thing for people to struggle with. But radical acceptance is really just accepting reality as it is, not as we want it to be. I don't know if any of you have ever heard of the term or phrase, it is what it is. But when people tell me that, oh my gosh, I get so aggravated because I get it. I know that it is what it is, but that's not how I want it to be. So with distress tolerance, these skills help us accept ourselves and our current situation. So it kind of helps us to understand that, okay, you know what? It is what it is. And does it suck? Yes. Does it hurt? Yes. But what can I do to try to work through that? It also teaches several techniques for handling crises, because sometimes when someone's in a crisis, then they tend to go to those unhealthy coping mechanisms. But some of the skills is distraction, improving the moment. So it's how to make a crisis situation bearable. Everybody identifies something. The way that somebody sees a crisis is different. So what I think is a crisis may not be a crisis for somebody else. But regardless, when our emotions are all over the place, any type of crisis situation is going to seem unbearable. So it helps us to learn ways to work through that rather than to break down. And it also helps us to self-soothe and thinking of pros and cons of not tolerating that distress. Sometimes when we have those distressful emotions, sometimes it's just easier to say, you know what, this isn't something that I can control, but I know that I can do something in order to help myself work through it. Distress tolerance techniques help us prepare for those intense emotions, and they also empower us to cope with them and have a more positive outlook long term, rather than just thinking, okay, life sucks and it's always going to suck. The third section is interpersonal effectiveness. So this helps us to become more assertive in relationships. It also allows us to express our needs and our wants without being manipulative, and also being able to say no while still keeping that relationship healthy and positive. I'd mentioned earlier that we find a lot of these interpersonal relationships that we have can be pretty big triggers for our mental health symptoms. So sometimes we have to work through that in order to recover. It also helps us to learn and listen and communicate more effectively, which is really good, especially when we're dealing with challenging people. And it helps us to respect ourselves and others. And again, when somebody's dealing with a mental health issue or a mental health crisis, we're agitated, we're irritable. So if somebody tries to spark up a conversation, we can get very, very angry, and it's not going to help the situation. And if anything, it's going to make it worse for us, because afterwards we may feel bad, guilty, or ashamed. And then that may allow us to engage in our eating disorder. So one thing I love about DBT is a lot of their skills are all acronyms. They all stand for something, and it makes it very easy to remember. So give is an example of one of the skills through the interpersonal effectiveness part of DBT. So basically they just follow through this to help them with that communication. So when we are being giving to somebody, we're being gentle. Excuse me, when we're having a conversation, we're not attacking them. Excuse me, I'm sorry, we're not threatening them, and we're not judging other people. The next is that we're showing that interest with good listening skills. Nobody wants to, be spoken to and the other person's just looking at, just staring off like they're not listening. They have no good eye contact, or they have their arms crossed like this. So that can create a lot of issues in those interpersonal relationships where it seems like we're not showing that interest. We can also validate. So we're acknowledging the other person's thoughts and feelings. And validation, can take some time. And I'm currently reading a book by Brene Brown. It's called Dare to Lead. And we just went over a section about sympathy versus empathy. And she actually has a video on sympathy versus empathy that's really good. It's just a quick, cute little video. But if somebody doesn't understand how to be empathetic, they could be taken the wrong way, especially if they're there to give them sympathy. That can really create a lot of issues. Or they may say, well, if you think that was bad, I went through this. How do you think I feel? Nobody likes to feel like they're not being validated, and we're not expecting people to fix our problems, but for somebody to just say, yeah, you know what? That sounds really crappy. That must have sucked. That's all we need. So validation can sometimes take some time to learn and be able to practice that effectively. And then the last is easy. So when you're talking and communicating, it's important to try to have that easy attitude, try to smile often and be lighthearted. If you just seem like you're an uptight person, or, have you ever talked to somebody and you're just talking about something, but the way that they are I don't know, the way they're talking, they just seem really angry, but they're really not angry, but it kind of makes us feel uncomfortable. And sometimes we want to get a little defensive because we feel like they're yelling at us. So that's why it's important to try to have that easy attitude and to be a little bit lighthearted when you're having those conversations. And then the last section of DBT is emotion regulation. This lets us to navigate our powerful feelings in a more effective way. So when we look at emotion regulation, some people can be if we have the spectrum of our emotions. So down this hand can be where they're completely emotionally numb. We definitely don't want that. But some people can also be at the complete opposite end of that spectrum. So they think, feel, live, breathe their emotions. And it creates a lot of interpersonal issues with themselves and also the people around them. So with emotion regulation, they learn skills that help them to identify, name, and change those emotions, and to be able to understand that, we can feel, but it doesn't have to be all the way up here. But we also don't want people to be completely emotionally numb either. So when people are able to recognize and cope with those intense negative emotions, it can reduce that emotional vulnerability they're experiencing and allow them to have more positive emotional experiences. So these are some resources on DBT. This is a book by Marsha Linehan. This is the one that I've read. She also has a workbook that has all of the work pages for DBT that you can use with your patients and clients. So I highly recommend DBT. Like I said, CBT and DBT are probably my two favorite therapies. It's just, they're very, very effective. And they just, even if somebody is not going through a mental health disorder or issue or concern, I feel like we could all use a little bit of DBT and CBT in our lives. But dialectical behavior therapy, dbtselfhelp.com, LenahanInstitute.org, behavioraltech.org, and psychpoint.com. So again, a lot of these, if you want to learn more about DBT, they also offer a lot of free and downloadable, if that's a word. If it is, I just created it, but sheets that you can download that you can use for your patients and clients. And then our last therapy is our acceptance and commitment therapy. So this is ACT or ACT. So this is a type of therapy, and it emphasizes the acceptance to deal with our negative thoughts, feelings, and symptoms, and our surroundings. So this is kind of similar to some things like with DBT, and it basically allows us to say, it is what it is, and I'm okay with that. With that, it also encourages increased commitment to those healthy activities that hold up people's values and goals. And the theory suggests that increasing acceptance can lead to increased psychological flexibility, which I believe that. The more we are able to be accepting, the more open-minded we are. And again, the more open-minded we are, especially when it comes to treatment for mental health, then we're going to see a better effectiveness. So ACT carries a lot of different benefits, and it can help people to stop avoiding certain things. There's certain thoughts or those emotional experiences, which can lead to those further problems. Because again, sometimes we go into that and we want to be emotionally numb because nobody wants to feel those painful emotions. I know I don't, but we know that that's not healthy. By avoiding those painful emotions, all it's going to do is create further issues, if not right then, sometime down the road. Now, how ACT is different with CBT. So the goal of ACT is not to reduce the frequency of those unpleasant experiences or those unhelpful thinking habits, emotions, or urges. So that's more of the CBT. So ACT's goal is to reduce the struggle to control or eliminate the experiences while increasing these meaningful life activities. So again, we're not trying to change those unpleasant thoughts, but our goal is to be able to say, okay, you know what, I don't always have to control those thoughts and feelings and emotions, or what I'm thinking and feeling doesn't define who I am as a person. I'm more than my eating disorder. I'm more than being, having bipolar. So that is where the acceptance part comes. So ACT also has 6 different components. So we have the acceptance piece. So that's pretty obvious. So we're allowing our inner thoughts and feelings to occur without trying to change them or ignore them. So acceptance is an active process. And like I said, I think that that's always been like a challenge for me. If there's something that I'm not super thrilled about, but I don't necessarily have the control to change it, sometimes just accepting it is what needs to be done, but that's not always easy. The other component is cognitive diffusion. So this is the process where we separate ourselves from our inner experiences. So it helps us to see thoughts simply just as thoughts, and they're stripped of the importance that our mind adds to them. So again, this cognitive diffusion helps us that, the way we think is not the way that it has to be or the way that it is. It's just simply a thought that we have in our head. The next component is self as context. So this involves learning to see our thoughts about ourselves separate from our actions. So I think this is a really good one that is important, because sometimes we, especially when it comes to eating disorders, our brains are constantly filled with these negative thoughts about ourselves. And so it's one of those, I think, therefore I am. So if, I tell myself, I'm dumb, I'm stupid, I'm never going to be able to recover, so then I assume that's what's going to happen. So if I'm assuming that I'm never going to recover, there's a really good chance that I'm not, because I'm not going to be able to, separate my thoughts based on who I am and my actions. The next is being present. So ACT encourages people to stay mindful of their surroundings and learn to shift their attention away from these internal thoughts and feelings that are unhelpful. The next is values. So these are areas of our life that are important enough to motivate that action. And whatever that is, whether it's children or a marriage, or, if it's your cat, I have lots of dogs and cats, and so if it's your cat that's motivating a person to recover and help themselves, then more power to them. So as long as they have something that is motivating them to motivate that action. And then lastly, we have the commitment. So this is involves changing our behavior based on the principles covered in therapy. So basically, we're allowing ourselves to make this commitment to accept the things that are going on in our life that we may not necessarily have control of. So that is ACT. So these are resources. And again, the Acceptance Commitment Therapy, the Process and Practice of Mindful Change. This is a book that I recommend if you want to learn more about acceptance and commitment therapy. And then these are resources. Again, you can get more information as well as free printouts and handouts, if you want to learn more. And, sometimes I'll print some of these things out and just do them for myself, because for me, it can be therapeutic. And even though I'm a social worker and I work in mental health, it doesn't mean that I'm immune from, having a really off day or a period of my life where it's like, I think, therefore I am. I'm dumb. And so I suck at life. Those are going to be common things that we experience. So sometimes I just need to step back and do some of these things to tell myself okay, it is what it is. Doesn't mean you're dumb. You're an awesome person. And you kind of go from there. So some of the websites: actmindfully.com, positivepsychology.com, actwithcompassion.com, learningact.com, and the apa.org. Again, has lots of resources and a lot of great information. So this is something I always put out there. If you are working with somebody or working in the community, if you suspect a medical or psychiatric emergency, such as threats of suicide, or if they're having these medical complications from eating disorder behaviors, to please seek medical attention or call 911 immediately. When it comes to eating disorders, a lot of times when somebody passes away from an eating disorder, it's usually because they may have, with binging and purging, they can have their electrolytes are kind of all out of whack from them purging and also having those lack of nutrients. So it can be common with bulimia for people to go into cardiac arrest or go into respiratory failure. And same thing with anorexia. People typically when they pass away, it's typically from their heart, and also their body just starts shutting down because it has been without all of the nutrients and things it needs to survive for a very long period of time. So this is just a little video, and this is through NIDA, but this is just tips for families to help a loved one that may be experiencing an eating disorder, because it's not an easy conversation. My mom and dad would tell you it was probably a really sucky conversation for them. And I made it even more suckier by my attitude and my anger, but it is an important conversation to have if you are concerned about a loved one.
Recovery is real. Help is available.
People often notice that a loved one or a friend is changing their eating behaviors or their attitudes toward food, towards weight, towards their size, towards themselves. It's really important to express your concerns about this in a loving and caring, supportive way. But also it's important not to wait too long, because the longer an individual is walking into the path of the eating disorder, the more physical and emotional consequences they'll need to face.
Learn about eating disorders so you will recognize the signs when you see them and know the difference between myths and facts.
Set aside some time to have a private conversation with your loved one and voice your concerns in a way that's honest and sympathetic.
Remind your friend and your loved one that you care about them and you just want them to be healthy and happy.
Be prepared for a difficult conversation. Someone who's struggling with an eating disorder is already scared, and it's extremely difficult for them to hear this kind of conversation. So when you do it with love and attention to their needs.
Oops, sorry.
Needs, not yours.
Share your own difficult experiences and painful emotions. It can be really important for them to know that they're not alone and that there's nothing wrong with them for struggling.
Don't give advice about weight loss, exercise, or appearance.
Avoid placing shame, blame, or guilt on your friend regarding their actions or attitude.
Don't oversimplify. Avoid saying things such as, if you just started to accept yourself, everything would be all right. Or if you just started eating normally, everything would be fine.
Use I statements. For example, I'm concerned because you don't eat breakfast or lunch, or it makes me afraid to hear you vomiting.
Set boundaries to preserve your own emotional well-being.
It's important to suggest that they seek professional help from a physician, a dietitian, a therapist, someone who understands eating disorders.
One of the most important things you can do is educate yourself about eating disorders. Dig into the facts. Go to the NIDA website. There continue to be lots of myths and misconceptions about these disorders, and you need to educate yourself about what's true.
I know I'm not the only one that struggles with body image and eating disorders.
My life in recovery is more beautiful than I ever thought possible, but I had to make that commitment to myself.
Recovery is real. Help is available.
All right, so the last part is just some ways that you can get help. So these are lots of really great resources and tools that can be used for yourself, loved ones, patients, clients, family members, anybody. So NEDA, the National Eating Disorder Association, they have an online chat where you could talk to somebody. They also provide lots of resources, free resources and videos for professionals as well as family. And then they also have a referral database. So if there was somebody that is, certified to treat somebody with an eating disorder, they typically can sign up and let them know, like, hey, I can see people that have eating disorders. So if you go to this database, you can search or you can put your address and they will locate services that are near you if there are some available. They also have a 24/7 crisis text line. So if you text NEDA to 741-741, you'll be connected with someone that you can talk to. NAMI is our National Alliance on Mental Illness. Their website's nami.org. They offer lots of resources on all mental health issues and disorders, including eating disorders. And they have free printouts, handouts that you can order, brochures, and they sometimes offer classes. So they may offer classes to teach people about mental health disorders. They also have classes for family members if they've had a loved one that was recently diagnosed with an eating disorder, not eating disorder, but a mental health disorder. These classes can teach people and family members how they can be there to support their loved one. ANAD is our anorexia nervosa and associated disorders. Again, this is another really great website. NEDA and ANAD are probably the two most websites that I go to for information on eating disorders, but they offer free information. They have online support groups, and then they also have a treatment directory and referral resource. So if you type in your address, they can let you know if there's anybody nearby that can treat somebody with an eating disorder. They have a phone number where you can call and talk to someone. If you're concerned that you have an eating disorder, if somebody else does, if you're looking for referrals, support, encouragement, or if you just have general questions. One thing that I do really like about ANAD is they offer a peer support mentor program. So it's almost like somebody who is in recovery, like either if they're in NA or AA, they may have a sponsor. So this is a peer support mentorship program that they have, but there are some eligibility requirements, and this is not done in person. So this is done by video chats or Zoom or anything like that. So for somebody to be a mentee, to receive a mentor, so number one, it's free, but the applications, they have to be an outpatient service. So they have to be seeing a counselor, and their therapist or counselor has to provide a recommendation letter for the mentorship program. Applications under the age of 18 will require parent consent. So if somebody's under the age of 18, they can still have a mentor, but they just need their parental consent. And people must reside in the United States, and all mentors have battled an eating disorder, but they've been in recovery for at least 2 years. So with the mentorship format, this typically lasts anywhere between 6 months to a year. So it's more short term. It's not, years. And they meet at least once, 1 hour of peer support every week. And again, like I had mentioned, this is done over the phone or computer. They are never, ever, ever allowed to meet face to face. So I just think this is a really great program. If you're looking for somebody to, mentor or sponsor or just be a support person that has gone through something similar, this is a really great way, because ANAD is, it's an organization and they monitor all of that stuff. So we know that if somebody is engaging in that mentorship program, that it is going to be safe. We also have SAMHSA, so that's our Substance Abuse and Mental Health Service Administration. They offer tons of free resources. I mean, literally like books. Like you can get some really great books and information on mental health disorders and treatment, as well as substance use disorders and treatment. Everything is free, even shipping. I used to teach social work classes at the University of Akron, and I probably ordered like 25 books. They were like 200 pages, and I got all of that for free. So please, if there's something on there that you think could be helpful or you can utilize, take advantage of that, because that's what it's there for. They also have a national helpline, and then they also have a crisis service where you can talk to somebody 24 hours a day, 7 days a week. And then here locally, we have our West Virginia Crisis Support Services. Their website is help4wv.com, and they offer resources and referrals for mental health and substance use concerns through a database. They have chat support where you can talk to somebody. They have a crisis support where you can talk to someone 24 hours a day, 7 days a week. It doesn't matter what day of the year. And then these are my resources that I used: ANAG, APA, NAMI, NEDA, NIM, psychiatry.org, and verywellmind.com. So if any of you have any questions, you can feel free to ask here. At any point, if you want more information, if you want to pick my brain, you are always, always, always more than welcome to contact me. You can email me at awagoner@missionwv.org, and I will be so more than happy to help you in any way that I can. If I don't know the answer, I will definitely research and try to find it for you. So please just don't ever hesitate to reach out if you have any questions or concerns. So I just want to thank everybody that attended today. I really appreciate it. Like I mentioned, this is such a huge passion of mine, and I love that West Virginia is starting to recognize that this is a problem, and we need to do something about it. So we need to be more proactive.
Okay, Autumn, we do have a couple questions.
Okay.
In the chat log, we have, how is radical acceptance different from sweeping problems under the rug? I'm not sure if that's more of a statement or a question. And then we have a pretty lengthy question in the Q&A.
Okay. So well, with the radical acceptance and sweeping it under the rug. So when we're sweeping it under the rug, we're just pretty much ignoring it, just pretending it's not happening or it never did happen. Whereas radical acceptance is we are acknowledging that it actually has happened, or we are going through that, and we find a way to be okay with that, to feel a sense of comfort that even though things are not okay, it's going to be okay. But when we're just brushing and sweeping things under the rug, that's when we are ignoring it. And when we are ignoring those issues, those concerns, those thoughts and feelings, essentially that's when it can come back and bite us in the butt, unfortunately. So I wish radical acceptance was just sweeping stuff under the rug, because I'll tell you what, my rugs would be full. But we just know that although we know that's a quick fix, it's not an effective way of treatment or recovery.
Okay. And the question that we have in the question and answer log is, what advice do you have for rural areas, places that have distances to travel for healthcare, or culturally avoid mental health services? especially those who completely avoid telehealth options. Where
Yes.
should a community start?
Well, one thing that you can do, so if we're looking at mental health, like altogether, not just specific to eating disorders. I mean, like you said, we do have the telehealth, which can be helpful and beneficial. But if you are wanting like that community to be more educated on mental health, a really great place to start is if you go to NAMI, which is the National Alliance on Mental Illness website. So they actually can, they can create kind of these mental health advocacy groups within communities that can provide that outreach, that communication, and different things like that to other people in that community. And, I can't imagine how difficult that must be. Number one, being in a rural area, like I know I live in a rural area, and it's like if I wanted to go somewhere, it's at least an hour drive. But then we also have that stigma as well. So, if you can always reach out to NAMI, it's free, for people to join and for it to get up and running. And they can also probably provide some trainings, like community trainings on mental health, just to educate people more. Did that answer all the question?
I think so.
Okay.
They did state that the area completely avoids telehealth options, but I think you answered it even though.
Yeah. Yeah, with telehealth, I mean, people can do telehealth because they can do it in their own privacy of their own home. So nobody else would necessarily have to know. Like if it's a youth, that's going to be difficult because we know that any type of therapy a youth wants to be engaged in that requires a parent and guardian consent. So that makes it tough if, they feel that they can't ask that adult, or if the adult says, no, you can't, I don't want you talking to anybody or going to counseling. And for those youth, I would definitely recommend them opening up to a school counselor or a trusted adult in the school, or a trusted adult they know, just so they can let somebody know, like, hey, this is what's going on, this is what I'm thinking and feeling, and maybe they can help them, provide some resources and tools to help.
Okay. Rebecca asked for resources about educating teachers on eating disorders. She was wondering where she might be able to find free resources or webinars. My first thought is to reach out to you and see if we could potentially schedule a training depending on location, that kind of thing. But what other options do you think there are?
Well, actually, that is in the work right now. The works right now with the West Virginia Department of Education. We are working together to create these resources for all staff and faculty in the schools on eating disorders and self-harm. But definitely those websites that I had mentioned earlier, like NIDA, NAMI, ANAD, really those websites are going to be really beneficial, just educating yourself more on those eating disorders. And wait, can you repeat the question? Because I felt like I had another thought.
She was looking for locations to find free webinars or trainings.
Okay. Yeah. So those
teachers. Yeah.
Yes, those websites will definitely be helpful. They have a lot of information, videos, tools, and resources. But that, just also that we are working on creating something. Now, if I don't know what county they live in, but I am doing presentations in Kanawha County. Is it Kanawha County? I think so. For some faculty in August, I believe, for like some school faculty.
Okay. I feel like there was something else. Jefferson. She's in Jefferson County.
Okay.
So maybe reach out. There might be something we can do to. No, that's not a county we typically serve, but that doesn't mean we wouldn't help. So
no, absolutely.
Lots and lots of people asking for copies of your slides. I assured them that you would give them to us so that we could share them out next week. I told them I would get them out next week. So if anybody had that question and it didn't see that in the chat log, Autumn will get me her presentation and I will email that out to everybody next week. I'm going to go ahead and put the CEU evaluation back in there. I've dropped it several times during the webinar, but if you need CEUs, make sure you fill out that evaluation. If you do not fill out that evaluation, I will not send you a certificate. Also, if you need a certificate of attendance, say you're a police officer and you need that for your service hours or for, you know, another particular, program, just fill out that evaluation, and where it says, do you need CEUs, just type in no certificate of attendance, because we only offer the CEUs for the social workers currently. So I can give you a certificate of attendance for anything else that you might need though. I don't see any other questions. So I think we're good.
All right. Well, again, thank you guys so much. Please do not hesitate to reach out to me. I can't tell you like how much all of this means to me. Somebody mentioned on here that West Virginia was lucky to steal me from Ohio. So that means so much to me. I hate Ohio. It's so dumb. I have to go there for the weekend in a couple of weeks and I'm just like, oh, so, but it's okay because I know I'll be coming back. But
I just is a true statement. We are so lucky to have you.
Yeah,
y'all are so sweet. Yes, I'm super grateful to be here and to do this. So like I said, don't ever hesitate to reach out to me. I don't know all the answers, but I will definitely find it for you.
All right. Thank you guys. I'm going to go ahead and end the webinar. If you have any more questions, go ahead and feel free to email them over to Autumn at the email address she provided. It's awagoner@missionwv.org.
All right. Bye. Thank you, everybody.
All right. Bye, Autumn.
Bye.